Hello, everyone. Our topic today is about pelvic pain. These are the objectives of the presentation. Chronic pelvic pain is defined as non-menstrual related pain below the umbilicus in men or women that has continued for greater than 6 months and creates functional disability or requires long-term medical or interventional treatment. CPP is an epidemic and it represents approximately 2 to 25% of the general population of women and estimated to cost around $881 million in the United States each year. From an anatomical point of view, you can divide the abdominal pelvic area into 9 areas: right hypochondriac, epigastric, left hypochondriac, and then here the right lumbar, umbilical, left lumbar, left iliac, hypogastric, and right iliac. And this is done through two imaginary lines. One of them is subcostal, and the other one is intertubercular. Male versus female pelvic anatomy. In the female, we have, of course, the uterus in the middle, and in the male, we have the prostate, and of course, we have the penis and the testicles outside. Besides that, we have the rectum and urinary bladder in both female and males. The innervation. So the first part of the innervation, the superior hypogastric, which supplies the sympathetic nerve supply. And then we have pelvic splanchnic nerves, which is parasympathetic, and it joins, in fact, the inferior hypogastric plexus. The inferior hypogastric plexus is both sympathetic and parasympathetic for both pelvis and perineum. And then we have the ganglion of impart, which is a sympathetic station for the perineum. Again, superior hypogastric plexus, right and left hypogastric nerves, inferior hypogastric nerves, and then this is the pelvic splanchnic nerves. I remember in my fellowship interview, they asked me whether we have one or two superior hypogastric nerves. So, of course, we have two here. All right. Lumbar plexus is the somatic supply of the pelvis here, together with the sacral plexus. All right. So here it's from T12 to L5, and the sacral plexus is from L4 to S4. Innervation of the prostate, testis, and scrotum. Prostate supplied by prostatic plexus or the inferior hypogastric plexus. The testicle is supplied by T10. This is a common question in the exam. Vas deferens from T10 to L1, epididymis T11 to 12. The prostate or prostatic plexus similar to bladder. Scrotum, ilioinguinal, and genitofemoral, and then you have the perineal nerve, which is basically a branch of the pudendal. somatic innervation. You can see here the T12 subcostal. Here we have the femoral branch of the genitofemoral, and here we have the genital branch of the genitofemoral. And then you have here on the lateral aspect, the lateral femorocutaneous nerve of the thigh. Down here on the right, you can see the pudendal gives innervation also to the perineum. Nerve supply of the hip joint. I know this sounds like a lot of information, but it has a lot of practical implications later on. So you have the nerve supply of the hip. You have the femoral, obturator, sciatic, nerve to quadratus femoris, superior gluteal nerve. And sometimes you have referred pain to the knee that can hide hip pathology and vice versa. Now, as far as we're concerned, from interventional, technical aspect, we have only access to the femoral and the obturator from the front here. Okay, so these are the branches that we ablate, during hip ablation here, radio frequency ablation. We ablate one of the branches of the femoral, and also the one branch from the obturator that supplies the hip joint, and also sometimes there is something called the accessory obturator nerve that actually also gets ablated. Now, from the posterior aspect, we cannot ablate the sciatic nerve, guys, because it's a mixed somatic nerve. It will end with paralysis. And the other nerves, there's no literature about them, but maybe we can inject them, but that's not the routine that we do for hip joint. We only access the hip joint from the front, but definitely you can, inject any nerve, including the superior gluteal, inferior gluteal, and nerve to quadratus femoris. The ones that are near to a vascular structure or a mixed nerve, probably you'll not be able to ablate it, but you can inject it. You can do pulse radio frequency. This has not been done up to now. Maybe in the future, this could be also added to the initial regimen for the hip RFA ablation. Okay, so what is the differential diagnosis of hip pain? L1-2 radiculopathy, ilioinguinal neuropathy, adductor, quadriceps, and iliopsoas muscle spasm, hip osteoarthritis and labral lesions, and lastly is the iliolumbar ligament dysfunction. This is a picture on the left here of a patient that's suffering from hip osteoarthritis. Non-gynecologic causes of pelvic pain: acute and chronic. Acute, such as diverticulitis, urinary tract infection, adhesions, hernia. Chronic, such as inflammatory bowel syndrome, irritable bowel syndrome, colorectal cancer, interstitial cystitis, and musculoskeletal problems. Gynecologic causes of chronic pelvic pain, or CPP: endometriosis, adenomyosis, dysmenorrhea, and others. We'll talk about them, during our presentation today. Causes of acute pelvic pain. First of all, if you have a childbearing, a lady in a childbearing period, you have to rule out pregnancy, guys. You have to rule out ectopic pregnancy, miscarriage, or red degeneration of a fibro. Gynecological causes such as ovarian cyst accident, ovarian cyst bleeding, after being uh, after rupture, or if there is kind of torsion there, pelvic inflammatory disease, and tubo-ovarian abscess. Bowel and urinary, such as appendicitis, bowel obstruction, UTI, calculi, and urinary retention. Neuro, such as nerve entrapment and disc prolapse. I want to mention something. I know it's kind of odd, but it happened to me several times during my career that they send me a patient. Let us say one of them was having an ovarian problem. It wasn't worked up yet. So I know this is not your job as a pain interventionist, but if you don't have carry this differential in your mind, you might send the patient to the wrong pathway. So anyway, we did the workup for the patients and so forth. One time they sent me a patient with urinary retention from the ER. I mean, I don't know who did that, but it doesn't matter. I'm just saying, you are a physician and you should be able to handle these patients. If you this is not your specialty, you send them to the appropriate specialty to take care of. Perineal nerve pain. Perineal pain could be related to pudendal nerve entrapment, and we see this in cyclists. Also, we can see ilioinguinal entrapment, like in hockey players, or genital nerve entrapment and injury. Myofascial trigger points of the small pelvis. As you can see, we have at least 10 distinct areas that can trigger muscle pain, starting from the levator, anterior levator, to middle levator, to sphincter ani, coccygeal and ischiococcygeal, prostate area, piriformis, obturator internus, and coccyx area. Pelvic floor myofascial syndrome, one of the under-recognized areas. And I'm showing you these muscles here because they're very important to know. Piriformis, levator ani, sphincter ani, coccygeus, obturator internus, quadratus lumborum, and gluteus maximus. Piriformis muscle syndrome. You guys are aware about piriformis muscle syndrome. Piriformis is a pear-like muscle that takes its origin from the front of the sacrum and it inserts in the greater trochanter. It's an external rotator, and the sciatic nerve is in close relation with this muscle. There's a nice classification for Beeson and Anson for piriformis and its relation with the sciatic nerve. And you can see we have at least 6 types of piriformis muscle anatomy here. Quadratus lumborum. Jeanette Ravel used to call this muscle the joker of the back because it's so common and it causes a lot of distress and gives you this picture of what we call lumbago. Anyway, quadratus lumborum, there are 2 parts. There's a superficial part and there's a deep part. And each of them, radiates in a different, pathway, sort of. Superficial in the upper, deep part of the quadratus in the lower. Of course, it can be part of the differential of sacroiliac pain and piriformis muscle syndrome can be confused with the quadratus. Facet disease, lumbar facet disease can be confused with quadratus lumborum spasm. Gluteus maximus. Gluteus maximus shows up three types of trigger points. Obturator internus. I mean, this gives you a kind of a perianal type of pain. Also, the sphincter ini, levator ini, and coccygeus. All of these muscles can give you kind of perianal, muscle pain. Okay, I'm gonna go through some of the, important syndromes. One of them is pelvic congestion syndrome. Okay, with pelvic congestion syndrome, the ovarian vein dilates due to valve failure or obstruction to flow. This causes varicose veins around the ovary, which can then spread to the pelvis, vagina, vulva, and potentially down to the legs. And this can cause pelvic pain. So this is one of the differential of pelvic pain here. Surgical management for this pelvic congestion syndrome. Total abdominal hysterectomy with bilateral salpingio-oophorectomy. And the second operation is ovarian vein ligation. And usually it gives somewhere between 73 to 78% cure or symptomatic improvement. And there's always establishment of collateral channels and recurrence of symptoms. Adenomyosis versus endometriosis. On the left here, you can see the endometriosis. And on the right, you see the adenomyosis. The adenomyosis is located mainly inside the muscle mass of the uterus itself. But endometriosis can implant anywhere in the uterus or the ovaries. And another syndrome here, you can see the pelvic inflammatory disease or PID. You have something called Chandler's sign, okay? And with Chandler's sign, you have severe cervical motion tenderness seen in PID. Major criteria: lower abdominal pain, tenderness, cervical motion tenderness, adnexal tenderness. So if you try to mobilize the ovaries, it will be hurting quite a bit. Supporting criteria: fever of 38, abnormal vaginal discharge, positive culture for Neisseria gonorrhea or chlamydia trachomatis, white blood count more than 10,000, elevated CRP or SED rate, and the treatment of PID is basically ceftriaxone and doxycycline. Interstitial cystitis. This is something that I've seen, I wouldn't say frequently, but I've seen many patients with interstitial cystitis coming to our pain clinic because really these guys are miserable, and usually these guys end with, taking opioids and are having issues with opioid addiction and so. But generally speaking, you find here with interstitial cystitis that the normal protective bladder lining is disrupted, and this will give you a thinning of the protective bladder lining, and you will see something called pinpoint bleeding or glomerulations on the bladder wall. And also another important sign is the Horner's ulcer. So the pinpoint bleeding and Horner's ulcers are pathognomonic for interstitial cystitis. Symptoms: increased urgency, reduced volume of urine, pain in the pelvis, pain during sexual intercourse. Okay, we'll talk about dysmenorrhea. We have two types of dysmenorrhea. We have primary and secondary. Primary, there is no identifiable pathology. Initial onset is 6 to 12 months after menses begins and is characterized by cyclic pain with menses that lasts 48 to 72 hours each episode. And then it will give you also cramping in the suprapubic region. Secondary, we have pelvic pathology. Initial onset years after menses begin. Pain is reproducible. Pain lasts 48 to 72 hours, days per episode. Again, painful areas vary in the secondary time. Dysmenorrhea symptoms: nausea, headache, loose stools, back pain, hip pain, dizziness. Another condition is called spastic pelvic floor syndrome or pelvic floor uncoordination or anismus. It's a functional abnormality characterized by involuntary, inappropriate, and paradoxical contraction of the striated pelvic floor musculature, evacuation of failure, and constipation. Paradoxical contraction of the puborectalis muscle. Puborectalis is hypertrophic and makes an impression on the posterior rectal wall during defecation. Etiology is unclear. Abnormal muscle activity, psychologic or cognitive. Anorectal manometry. This is a very important concept here. Increased pressure at rest during defecation. Spastic floor syndrome is a type of pelvic floor dysfunction where the muscles in the lower pelvis are in spasm or a state of constant contraction. This can lead to symptoms of constipation, straining to defecate, urine or stool leakage, and a frequent need to pee. Initial treatments include biofeedback, pelvic floor physical therapy, and medications. Proctalgia fugax is characterized by recurrent, severe, and episodic anal pain that lasts seconds to minutes with no pain in between episodes. This is extremely important, guys, to really pinpoint proctalgia fugax. There has to be no pain in between the episodes. And there is also a diagnosis of exclusion. So, you don't have any reason behind this, anal pain. So, one of the treatments that we use is, something like beta agonists, such as salbutamol, also calcium channel blockers, Valium, and sometimes we do inject botulinum toxin. I myself, I use Valium at night, 5 milligram at night. The reason is there are a lot of psychogenic elements involved with this type of pain. And really, when the patient takes the Valium at night, it helps him go to sleep. 5 milligram is not a huge dose. Of course, you have to be super careful with benzos, as you know, because benzos, you know, could be very addictive to some patients. But generally speaking, works good. This little diazepam, 5 milligram at bedtime, helps a lot of these Proctalgia fugax patients. Bladder cancer. Signs and symptoms of bladder cancer. Blood in the urine, oliguria, dysuria, pain during urination, tiredness, anemia, abdominal pain, flank pain, weight loss, incontinence, and lower back pain. Chronic pelvic pain algorithm, like we mentioned in the past, for low back pain, neck pain, we try to develop some sort of an algorithm to give you this map of how you manage these cases. So step one, usually conservative. Step two, anesthetic pain interventions, and step three, surgical interventions, including microdenervation of spermatic cord, pre-sacral neurectomy, intrathecal pump, or dorsal column stimulator. Conservative measures: education, bed rest, psychotherapy, physical therapy, acupuncture, TENS, and drug therapy. Bed rest should not be more than 72 hours. Medications treatment to chronic pelvic pain: NSAIDs, acetaminophen, and then the regular stuff: antidepressants, opioids, anticonvulsants. But there's an addition here, which is, contraceptive pill, gonadotropin releasing hormone analogs, and danazol. So this is something that you can add to the usual list of medications. And that's why we're going to talk about oral contraceptive pills, or OCP, address cyclic pelvic pain related to ovulation, endometriosis, premenstrual dysphoric syndrome. Gonadotropin releasing hormone analogs results in ovarian suppression and hypoestrogenic environment for endometrial stroma, thus inhibiting the inflammatory cascades associated for endometrial proliferation. Gonadotropin releasing hormone analogs are still used as a second line regimen and has a higher incidence of chronic pelvic pain after termination of therapy. Danazol, this is a little bit different here. This is an oral androgen that is decreasing the release of gonadotropins from the pituitary and thus preventing endometrial proliferation. Vitamin B1 in one study has been used 100 milligrams for 90 days and resulted in 87% cure rate up to 2 months post-treatment in dysmenorrhea. Don't ask me why B1 versus other vitamin B, is the only chosen one that helps with pelvic pain. I'm not sure. But this is a study that's published already. Mindful meditation. Mindful meditation was developed by John Kabat-Zinn. John Kabat-Zinn basically studied yoga and basically um, kind of took the religious aspect, out of the equation from yoga exercises, and he used it as a mindfulness, technique that became very popular all over the Western Hemisphere. And this picture is basically for John Kabat-Zinn himself. Yoga. Another technique called progressive muscle relaxation. And I use this a lot, with my patient. Teach them how to relax their muscles. And this was developed by Edmund Jacobson. And usually you start with their feet and you go all the way up to their face here. Ask the patient to relax, them in a sequential form, like this picture, from 1 to 12. Acupuncture has been used for pelvic pain. And I want to let you know there's a beautiful point for pudendal neuralgia in particular that I use. It's not a traditional Chinese point, but it's extremely useful. This is it. This is it actually, and you can find it uh, between the PSIS and the ischial tuberosity. So midway between the PSIS and the ischial tuberosity, you will have this point for acupuncture stimulation for the pudendal nerve. I've done this, and it really helps if it's a pudendal neuralgia. Then we have biofeedback techniques. These really helps patients, by giving a feedback on blood pressure, heart rate, and muscle tension. Interventional techniques for, chronic pelvic pain. We start with trigger point injections for, piriformis, levator, ani, gluteus maximus, thoracolumbar steroids like epidural, lumbar facet, sacroiliac, peripheral nerve blocks like pudendal block, iliohypogastric, ilioinguinal genitofemoral, sympathetic chain blocks such as superior hypogastric, inferior hypogastric, and ganglion impart, neuromodulation with intrathecal, narcotics and spinal cord stimulation. And lastly, surgical techniques such as diagnostic laparoscopy and hysterectomy, pre-sacral neurectomy. And this is basically, in a sequential form here, how to work it out, until you reach, intrathecal narcotics or dorsal stimulation. This is a picture of an interlaminar epidural steroid. This is another picture for caudal epidural steroid injection. Caudal epidural, by the way, is a very useful injection. I want to say that the correct terminology should be sacral epidural steroid. However, we're all of us, we know the other terminology, which is caudal. With the caudal injection, if you inject 10 cc of fluid, from the sacral hiatus, this will reach the L4, L5 level, in at least 89% of the patients. Piriformis, and you can inject the piriformis below the sacroiliac, and you can inject it above, the head of the femur here. Now, This one is safer, but I like this one more because you inject in the middle of the belly of the muscle. However, you might encounter the sciatic nerve while doing this injection. Remember, we said that there's a correlation between the sciatic nerve and the piriformis muscle. So you gotta be careful, not just because you don't want to damage, of course, the sciatic nerve. Quadratus lumborum and psoas major. So here on the left, quadratus lumborum, and on the right, psoas major muscle. Other nerves of concern are the genitofemoral nerve, both the genital branch and the femoral branch. Now, I want to say that a genitofemoral neuralgia can happen after radiofrequency ablation of the lumbar sympathetic chain. They love this question in the exam. Okay, so take a note of it. Neuralgia paresthetica is the entrapment of the lateral femorocutaneous nerve. As you see from this picture, the lateral femorocutaneous nerve could be under the ligament, or over the ligament, or over and under the ligament, or it could be over the iliac crest. So that's why it's very helpful to do it under ultrasound guidance, like in this picture. Iliohypogastric and ilioinguinal blocks is also very commonly done injections here. Also, genitofemoral nerve. With iliohypogastric and ilioinguinal, you can do them with ultrasound guidance. This is the genitofemoral, and as I said, you can block the genitofemoral. You can do it while it's located in front of the psoas muscle, or you can inject the terminal branches of the genitofemoral, which is basically one of them is the genital branch and the other one is the femoral branch. Like here on the left, you'll see the femoral branch of genitofemoral and the genital branch of the genitofemoral. Genitofemoral under C-arm. Just stick your needle, next to the pubic tubercle. This is genitofemoral, while the patient in the prone position. You basically go through the psoas muscle and you inject it. Those are column stimulators and peripheral nerve stimulators. So these are new technology that's in progress. Pelvic pain can be, handled with intrathecal neurolysis, all right, or intraspinal drug delivery, superior or inferior hypogastric, and lastly, sacral nerve root blocks. Superior hypogastric plexus block. It's kind of a relatively recent injection developed by Dr. Plancarte from Mexico. He was the head of the pain department in Mexico City. And basically, you put two needles while the patient in the prone position at the level of L5S1. Here's a transverse section for the superior hypogastric plexus block. Inferior hypogastric is kind of a interesting injection. Unfortunately, it's kind of a little bit sophisticated to do. And with this one, you go through the sacral foramina and then you inject your locum. You try to bring your needle outside the anterior sacral foramina. So you go through the posterior foramina and you get out at the anterior, aspect of the sacrum. And that's why you'll see the picture on, on the left here. You will see the contrast is bathing the anterior front of the sacrum. I mean, of course, you can do this with neurolytic agents as well. You can do the sacral nerve root blocks, and you can do neurolysis of these either with radio frequency or with neurolytic agents. And this mainly are used for somatic pain, the sacral nerve root block and neurolysis. Pudendal nerve block and neurolysis. I see a lot of these. Okay, the pudendal nerve is a nerve that's coming out of the sacral plexus, coming off the lesser sciatic foramen, and then it divides into three branches. Okay, a deep perineal nerve, a superficial perineal nerve, and also inferior anal nerve. Usually, we inject the pudendal at the tip of, this triangular spot here, and you hit the bone, and then you inject your local and steroids. Perineal pain, and you can do also pulsed radio frequency if you like to. Perineal pain can be handled with pudendal nerve blocks, ganglion of impar nerve block, and subarachnoid neurolysis. Ganglion of impar. This is another block that was developed by Dr. Planck Comte, and the head of the pain department in Mexico. And this guy, in fact, was putting his needle below the coccyx here from this side. And of course, you have the rectum here. So you have to make sure that you put a finger in the rectum so you don't injure the mucosa while, doing this procedure. Nowadays, nobody's doing it this way. We go actually from the sacrococcygeal junction here, like in this picture. As you see, the needle, sacrococcygeal junction, and the contrast, it gives you what we call a coma-like picturing. Pumps are also useful in pelvic pain, especially programmable pumps, but these should be reserved for patients with intractable, cancer pain, with the lifespan probably more than 6 months. We stick the catheter intrathecally, and we thread it to T11 area, and the pump itself is usually inserted in the abdominal subcutaneous fatty. Dorsal myelotomy, it's a procedure that not frequently done because it needs a special training in it. Usually these guys that do this dorsal myelotomy, we call them functional neurosurgeons. And basically we ablate this area around, the gracile and conuate tract. We found that this uh, area is the one that supplies the visceral impulses to your brain, coming out from the pelvis and from the abdomen. So it's used in severe intractable pelvic visceral pain. Subarachnoid neurolysis. It's an old procedure, low tech. It doesn't need C-arm. However, its indications have really, you know, uh, came back quite a bit since we have alternatives nowadays. But you can still see it in some of the developing countries here done. Generally speaking, for the sake of going into the important part of this block here, we use it mainly in two situations: chest, intractable chest pain, and intractable perineal pain. Remember these two indications. Don't do it anywhere else. Subarachnoid neurolysis. Of course, we try to use phenol in these cases, so it gives you a saddle block. Since uh, phenol with glycerin is hyperbaric, and it's easier to do it this way. Do the block, put a little bit of phenol, let the patient sit up for some time until the block covers the saddle area. For anesthesiologists, this is a routine procedure that we do for like uh, you know, uh, hemorrhoids and stuff like that, anal surgeries. But of course, in this situation, we inject local anesthetic, like bupivacaine, for example. Paracervical and pudendal blocks are used in labor as well. Paracervical in the first stage, pudendal in the second stage. The problem with paracervical block, it can cause fetal bradycardia. By the way, the paracervical block is done by putting a needle just next to the head here, okay? Um, in this plexus. This plexus actually is part of the inferior hypogastric plexus. While the pudendal nerve block is done blindly, usually, or landmark technique, I'd rather say it this way, by putting a finger in the vagina and feeling the ischial spine. Remember when we talked about, doing a pudendal block under X-ray, and we said that we're gonna look at the ischial spine, and we're gonna basically hit the tip, while the patient is in the prone position. You can do it also a landmark technique while the patient in the lithotomy position. Okay, it's easier for ladies because you can do it, transvaginally, and you can feel the tip of the ischial spine with your finger. Of course, you have to protect yourself while you're doing this. Surgical management for chronic pelvic pain could be a diagnostic laparoscopy and hysterectomy, robotic surgery, laparoscopic presacral neurectomy, and microdenervation of spermatic cord. Diagnostic laparoscopy and hysterectomy. Diagnostic laparoscopy is useful in identifying pathology associated with endometriosis, pelvic adhesions, and pelvic congestion syndrome. Several studies have confirmed the efficacy of diagnostic laparoscopy with improved pain scores and fertility. More invasive surgeries, such as hysterectomy, may be warranted in patients who failed conservative measures and have extensive endometrial implants. This is basically an example for endoscopic surgery. Robotic surgery offers a new method to surgically address chronic pelvic pain. Newer evidence suggests that robotic surgery may be faster than traditional laparoscopy with less blood loss and lower pain scores. This is an example of robotic surgery. Laparoscopic presacral neurectomy is a surgical removal of the presacral nerves lying within the boundaries of the interiliac triangle. Several studies report reduction in analgesic use, pain scores, and improved sexual function. Potential risks include rare injury to the vena cava, iliac arteries, chylus ascites, back pain, and urinary retention. And this is basically an example of laparoscopic presacral neurectomy. Key learning points of this presentation: chronic pelvic pain is multifactorial in its generators of pain, a thorough history and physical, coupled with properly selected diagnostic imaging, physical therapy, pharmacologic management, and successful interventional treatment algorithm should be followed. Thank you.